warm good evening to everyone. So, I am Dr. Nitin Bhartia, MD Medicine, practicing at Dibrugarh Aditya Hospital. So, before wasting much of the time, we should start with what we are here for at present, the update on hypertension. So, what is hypertension? How it affects? More or less, we all have a knowledge. But what are the recent advances or what are the latest update in this? We are here to talk about. Before COVID, non-medical people have no knowledge about what is WHO. But after COVID, everyone has a knowledge about WHO, World Health Organization. So what does WHO has to say about hypertension? As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular death, which affects 45% people in the age group of 40 to 69 age. Raised blood pressure is one of the most important risk factor for cardiovascular deaths or cardiovascular diseases. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over the last 30 years to 38% in men, whereas it was previously 29%, and it has gone to 32% in women from previously 28%. Despite that, half of the people, or approximately 50-51% of the men and 40 to 41% of the women with hypertension were unaware of the condition that they are hypertensive. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get any treatment. Medication was used to control blood pressure in less than 1 out of 5 and 1 out of 4 men and women respectively for hypertension worldwide. Next is International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource-poor countries, optimal care refers to evidence-based standard of care, and where essential standards refer to minimum standard of care to allow specification of essential standard of care for low-resource country. Like at the first setting, patient should be started with an antihypertensive drug because there will be loss to follow up. So we cannot wait that for the next reading that when the patient will come for the next time, we will have a reading and we will start with the antihypertensive drug. The next update was from the American Heart Association, AHA, released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low ASCVD risk. Among low-risk adults or with no ASCVD or 10 years CVD risk of less than 10% with stage 1 hypertension, blood pressure 130 to 139 and 80 to 89 for diastolic blood pressure. Management starts with non-pharmacological therapies like diet restriction, salt reduction, brisk walking, exercises, yoga, or anything of that sort. If blood pressure remains uncontrolled at the end of 3 to 6 months, consider starting pharmacological therapy for those patients as well. So we don't need to wait till the pressure goes beyond 140. If 3 to 6 months from non-pharmacological methods, if we are unable to control the BP, go with the drugs. Start with a low dose, but go with it. Acute respiratory distress syndrome is a potentially fatal condition involving lung damage, and experts often associate with severe COVID-19. A recent study, which appears in the Journal of the American College of Cardiology, reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. So this one was a new finding which we got during the COVID period. Metoprolol has its effect. Lowering systolic blood pressure targets down to the 110 to less than 130 millimeter range. Substantially reduce cardiovascular adverse effects in the STEP randomized trial, affirming the SPRINT findings for an older Chinese population. Among some 8,500 patients between the age 60 to 80 in China, the intensive treatment trimmed 26% of the composite cardiovascular risk. Findings from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies ranges from threshold of 130 to 150. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on office BP measurement, but also on out-of-office measurement such as ambulatory blood pressure monitoring or home blood pressure monitoring. 24 hours and nighttime blood pressure monitoring were associated with greater risk of mortality and of composite of cardiovascular outcome. Thus, they may be considered as the most relevant measurement for estimating cardiovascular risk. For every systolic 20 and diastolic 10 mm mercury increment of BP measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs considering high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of AC inhibitors or ARB plus calcium channel blocker or a diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely N-nitrosyl-dimethylamine (NDMA), which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminant valsartan from Jalhan Huhai every day for 6 years in the highest dose, it could result in 28 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had been taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visits of more than 6%. The HYG study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HYGA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable cardiovascular risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary cardiovascular outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The RR reduction for cardiovascular events was significantly improved for nighttime treatment when compared with awakening treatment. So with this, we come to the end of our presentation on the recent updates on hypertension. With this, I'd like to conclude. Thank you.